So good evening, everybody. For those of you who don't know me, I'm Trevor McMillan, and I have the great privilege of being the Vice-Chancellor here at Keele. And it is a special pleasure for me this evening to welcome you to this next in the lecture series associated with the Institute of Liberal Arts and Sciences. A number of different reasons for that. Partly, again, for those of you who aren't used to the idea of ILAS, this is an organisational unit that we set up probably about 7 or 8 years ago now to really help facilitate interdisciplinary work across the university, both on a research side and on an education side. And as we celebrate our 75th anniversary, it's pertinent to mention that one of the reasons for doing that was indeed around the tradition and the history around Keele. That was very much focused in the early days on that interdisciplinarity, and actually probably more multidisciplinarity, I would argue, at that point, where a very firm belief that the major challenges of the day in 1949, both in terms of what universities needed to do in-house, but also in the skills that they needed to give the students in order to survive in what was then a very uncertain world. A feeling that actually as a university, we still believe that ethos is as relevant now as it was then, and also that we should try and do something about it. So that's the background for ILAS. The other reason it's a pleasure this evening is that this evening's speaker is Professor Ian Cumming, OBE. I've got a series of notes here and around. Ian is our Professor of Global Healthcare, Workforce and Strategy. I wouldn't have remembered all of that without it being written down. And he's been with us since 2020. Before that, he was Chief Exec of Health Education England. But at the time he started with us, he also became the Ambassador for Health in the UK's overseas territories, as well as being appointed to be the Chair of the West Midlands Ambulance Service Trust. But again, my pleasure comes from even before that, because I was working out last night. I think I've probably known Ian now for not too far short of 30 years. When I arrived at Lancaster University in 1995, Ian was, I don't know how long you'd been in the post at that point.
More or less arrived at the same time.
About the same time. As Chief Exec of the Hospital Trust up in Morecambe Bay, and then became Chief Exec of the local PCT before moving into the Midlands as the Chief Exec for the West Midlands Health Authority. Ian, even at that very early stage when I was introduced to him, was described as one of the most enlightened chief executives in the NHS, and that was coming from a university where what that means is that he really appreciates what universities do, because actually he wanted to work with us in different ways. He pushed forward all sorts of connections on both research and education, and I have to say one of the more enjoyable periods in my career, and it had its ups and downs at various times, when I had the pleasure of working with Ian to actually develop and form the medical school up at Lancaster. So Ian and I have worked quite closely for many years. Now I just get sort of envious of a lot of the travelling that he's doing and a lot of the nice places that he gets to in his ambassadorial role. But one of the relief points of this evening is that he's here at all, because he landed on the incoming flights from Santiago that sort of brought him from the Falklands overnight, and he only got into Heathrow this morning. So I have to say, when I was following him on Facebook last week, seeing his problems around getting to the Falklands, I was a bit concerned that he might not actually get back from the Falklands in time to deliver his lecture this evening. But nevertheless, he's here, and Ian, you are very, very welcome. Look forward to hearing your talk, where I've got the title here somewhere, but it's around health workforce into the next 10, 15, 20 years. Yeah.
Thank you, Trevor, for that very kind introduction. 30 years, we must have been children. It has been a great privilege for me to join Keele University and to meet so many new colleagues from the university, but also broader afield in this next phase in my working career. what I've been asked to do tonight is to think a little bit about some of the challenges and issues facing healthcare systems around the world, although I am going to give this something of an NHS flavour, and to look at how some of the opportunities and threats may develop over the next 15 years or so as we try and provide a new sustainable healthcare system around the world. So in thinking about this, I found a cartoon which could actually represent today's NHS in many ways. This is 15 years old, and it was suggesting at the time that the NHS was underfunded, the NHS had a shortage of workforce, and was being propped up on a day-to-day basis rather than having a long-term sustainable vision for the future. Now that was 15 years ago. But actually, that feels like the NHS that many people in this room work in today. We are really stretched, we're under real pressure, and I think I could speak for the majority of people who work in the NHS to say that we're not providing a service that we're proud of at the moment. Although this slide is a picture of the NHS, I also believe that I've spent the last 38 or so years of my career not working for the NHS, but working for the NSS, the National Sickness Service, because if I actually focus on the amount of time that my career has been devoted to health, it's been tiny. And one of the first messages that I would like to give tonight is that unless we make this shift from focusing on illness, from focusing on diagnosis and treatment, towards focusing on prediction and prevention, we are never going to flatten the curve of demand for healthcare. We have to be serious about prediction and prevention and not just focus on diagnosis and treatment. So, how does our NHS of today differ from the NHS that we'd have seen when it was formed in 1948? Well, of course, it's changed dramatically. Some of you may be familiar with the statement that was issued by Naib Evan at the time when he was reassuring colleagues in the Houses of Parliament that funding for the NHS would drop in real terms year on year because the population would become healthier and therefore we wouldn't need to invest as much in providing healthcare. He got a lot of things right, but he got that spectacularly wrong, didn't he? Because our ability to do more and more and more, our ability to keep people in relatively good health for longer, our ability to embrace new technological advances and the costs associated with those has outstripped any government's attempt to keep pace with NHS funding. But of course, the founding premises are still true. So we have universal access to a healthcare system which is free at the time of need, and it has liberated people from that fear of unaffordable treatment or illness that they just don't know how they're going to seek a diagnosis for. I remember a story that my grandmother used to tell about when she was giving birth at home to my dad. So this would be 1930. So before the National Health Service, and it was a complicated delivery. The midwife phoned for the doctor to come, and the doctor arrived. My grandfather's biggest concern was how he was going to pay the doctor. Not the health of his wife, not the health of his unborn child, but he got himself into a complete panic. They weren't well off about how he could fund the medical call out. Fortunately, the outcome was good. My dad was born fit and well. Quite how, when my grandmother was tiny and he was 12 pounds, I don't know, but anyway. But the outcome was good, and the doctor agreed to waive his fees. As a result of which, my dad's middle name was the doctor's name because they were so grateful. And I think for many of us that have been used to a National Health Service that is there for us in one form or another when we need it, we don't actually realise just what it was like pre-1948. But of course, the NHS costs an enormous amount of money. £175 billion of public money is going to be spent on direct provision of healthcare this year. If you add on all the other factors like the costs of the Department of Health and capital funding and things like that, that figure goes much higher. But we're spending £175 billion of public money this year, which is over £3,000 per capita in terms of the scope of how much we're spending. And we employ 1.6 million people. So we're by far the largest single employer in the United Kingdom. We are in the top 3 or 4 in the world in terms of the largest employers. Indian Railways and the Chinese Army always beat us in terms of number of employers. But other than that, we're up there. There is still a huge degree of public support for the NHS. Now, the criticism of the NHS is growing, and at times that's entirely justifiable, but there is still a huge degree of public confidence and a real desire to maintain a service that's free for all at the time of need. But the NHS has always been and will always be a political football. It is always in any opposition party's interest to criticise the government of the day's stewardship of our National Health Service. That's irrespective of which political party is in power. That has always been the case. What's good about the system? Well, compared to most other healthcare systems around the world, actually the administrative costs of running the NHS are very low indeed. And that's because we have a single payer, in effect, in terms of the government. One of the real jewels in the crown of the NHS is our primary care service. Really struggling at the moment because of demand, but the concept of registering every member of the population with a primary care service who can take an overall responsibility for the health of that individual is something that does not exist in many countries. And the way in which our GPs are able to manage risk on behalf of the rest of the system by taking large numbers of patients who are accessing them on a daily basis and determining which of those patients need to go on for investigations, treatments, or referrals to secondary care really suppresses the cost of running a healthcare system. And it is absolutely the jewel in the crown. As I travel around the UK overseas territories, so many of the overseas territories would love to move towards the model that we have in this country, but for various reasons, they're unable to. But this concept of population health is really important, and we must hold on to that. It links to the way in which we pay our clinicians. So I do some work with the Cayman Islands, and I believe that the Cayman Islands have more MRI scanners per capita than anywhere in the world, which, guess what? They do more MRI scans per capita than anywhere in the world. All those MRI scanners are privately owned, privately funded, so there is an incentive to keep them busy because they are businesses. So they are running for 6 days a week from relatively early in the morning to relatively late at night. And some would argue they are doing an awful lot of unnecessary MRI scans, which is a significant cost to government, to the health insurers in Grand Cayman. The way in which we fund people on a salary basis through the NHS is a way of making sure that we aren't over-investigating, we aren't over-treating, and also the equity that we have in terms of a consultant surgeon being paid the same as a consultant radiologist or a consultant anaesthetist is not something that you would find in many other countries around the world, which does, on the NHS side at least, allow people to choose a speciality on the basis of genuine interest and not be motivated by the flow of money. Free at the point of delivery means that people can present for treatment when they need it. There have been various experiments around the world to move away from this. Some healthcare systems do charge. There was an experiment in Australia not very long ago where every patient presenting to see a family doctor had to pay, I think it was somewhere in the region of £7 converted to our currency. It was wound up after a year because it was costing more to collect the money than they were actually collecting in terms of income. By the time you built collection systems in place, you put auditors in place, you put accountants in place, you put administrators in place, just wasn't worth doing. And of course, there's a risk that it keeps the people away from the healthcare systems that we actually really need to be seeing. Therefore, you're resulting in delayed diagnosis when actually we need to be seeing people as soon as possible. A single health system supports planning of a common sporting infrastructure. Bit of a question mark on that, but some of you will be familiar with the integrated care systems, integrated care boards that we now have placed. And certainly there's a lot of work going on to try and harmonise financial systems, HR systems over a much bigger footprint to save every individual organisation from doing their own thing. I've already mentioned the high degree of public support, and particularly public support for the fairness of the system, because you are seen on the basis of clinical need. You're not seen on the basis of how much money you've got. Obviously, private healthcare is different. And then I've put 2 question marks on the end of access, because 10 years ago, the NHS was in a pretty good place with regard to access to primary care, access to diagnosis, diagnostic tests, and access to secondary care opinions, and indeed definitive treatment. We've lost much of that. And some of the waiting times at the moment are unacceptably long for people to access healthcare. And that's going to be one of the real challenges. How do we catch up with the COVID backlog that we are still dealing with? And I would suspect we're going to be dealing with the next 2 to 3 years at the very least. But then how do we make sure that we've built a system that is responsive to the needs of the population? Challenges. So the NHS is political football. The NHS doesn't do change very well. We like to pretend we do, but if change is our idea, it's a really good idea. If it's somebody else's idea, we don't like it. The amount of times that I've travelled around the country, and indeed more recently around the world, and I've seen an absolutely fantastic idea of something to do with healthcare, you then try and bring that into a different part. Oh, well, that might work in London. It won't work in Leeds. Well, it works in Stoke, but it certainly won't work in Birmingham because our population is different. What they mean is it's not our idea. We don't like it. We want to reinvent the wheel time after time. And I think there is something there that we need to look at in terms of how much freedom and individuality do we allow NHS organisations, and how much do we actually say, do you know what, this is the way we're going to do it? Unpopular, controversial, but I actually do think we need to head in that direction. Commissioning systems, well, are we still commissioning healthcare anymore? We've kind of moved away from that phase of the NHS in many ways. And as a result of which, choice and competition in healthcare, which was for many years seen as the driver of improving quality, has kind of fallen by the wayside. So some of you will remember systems called Choose and Book, when you could go and see your GP and your GP could offer you a range of appointments when it worked for different healthcare systems. We've very much moved away from that. But of course, one of the biggest challenges we have is that we are funded by the UK government. So when the UK government has got no money, the health service doesn't see an increase in its funding, irrespective of what the demands are from the population. Or if it does see an increase in its funding, it's associated with a decrease in another public service funding to try and keep that budget overall. More on that in a moment. And then finally, I've put British culture on there. We still have, particularly amongst some of the older members of society, a real perspective that, well, I won't trouble the doctor, it'll be all right, it'll go away. Or, you know, I'll get better and I'll give it a few weeks and see what happens. And as a result of which, one of the things that we do find here, compared to many of the European countries, is that people are presenting quite late with conditions, which in some ways is unusual because it's almost the opposite of what you would expect, having just described the primary care system that's in place. But we see cancers being diagnosed later. We see some other conditions being diagnosed later because there still seems to be this view, well, I won't bother the health service, they're very busy. And actually, I think at the moment, there's a risk of that getting worse because of the access problems. People are thinking, well, I'll just literally see what happens. They're all very busy. So I've mentioned that we spend an awful lot of money every year. This is from last year's budget from the Treasury, and this is how the public purse is divided up in the United Kingdom. So social protection, so that's pensions, unemployment benefit, sickness benefit, things like that. So that's the largest piece of the pie, 29%, 341 billion pounds a year. The second largest area is health. Now, this is not the same figure as presented before because this is UK wide. So this includes Scotland, Northern Ireland and Wales. So we're spending 20% of the entire income into the Treasury on our healthcare system in the United Kingdom. That's a huge amount of money. And if you then look at the next biggest, which is education, 131 billion, and transport at 62 billion, and defence at 68 billion, you can basically add those three together to get to the amount of money that we're spending on healthcare. Now, that's a problem whenever it comes to the discussions and the debates and the arguments every year about funding for the NHS, because a very small percentage increase for health is actually a very large amount of money to all these other spending areas. So the spending round every 3 years, it tends to be now, always starts with all these other government departments saying, don't give anything to health. Because they know that the more that's given to health, the less that they get. 1% increase on the health budget is an awful lot of money to policing, for example. So that's a challenge that we actually have. Those people that are here from the Global Health MSc will know that I really dislike this slide, but I put it in anyway. This is a comparator of health spend across OECD countries. And you will see that the United Kingdom is here. So more or less spending the average across the EU 28. You may ask why I'm giving you 2018 figures. The reason for that is that I personally do not believe that the data are robust for the COVID period because different countries spent money on COVID in different ways, and I don't think it's a fair comparator. So I'm sticking with this until we get 2023 data published, and then I think we'll actually have a more robust measure back. So 3,000 euros per person being spent on healthcare by the United Kingdom puts us in the middle of the pack. Why don't I like this slide? Because this tells you absolutely nothing about the quality of healthcare being delivered. So is the quality of healthcare in Switzerland twice as good as the quality of healthcare in the United Kingdom? Well, I don't know is the honest answer to that question. Knowing some people that work in Switzerland, I suspect the answer to that is no. But I genuinely don't know. So it's not the most meaningful slide, but it does show that we're not a million miles off the rest of our neighbouring countries in Europe. Now, this one's interesting. Number of hospital beds per 1,000 of the population. This is us. Are we starting to understand why some of the pressures that we're seeing in our hospitals that are overflowing into the rest of the healthcare system are coming into being? I don't know, because again, this doesn't tell you anything about the quality of healthcare being delivered. It's simply a count of pieces of furniture. You need to understand what the overall healthcare architecture is and what the infrastructure is that supports the people in each of those healthcare beds. Also, some countries, particularly as you head up to this end of this chart, they include things like hospice beds in the numbers, whereas we don't. And they would also include what we would class as nursing home beds in the numbers that we don't. So again, it may not be quite as useful, but it certainly shows that we're down with Mexico, Costa Rica, Colombia, Chile and Sweden in terms of the number of beds we have. And if you look to kind of our main European competitors, they're here. So we know that money is going to be really, really tight over the next few years. There's two approaches to this. The first is, how do we deal with this reduction in real terms resource? How do we cut effectively? The second one is, no, let's take this as an opportunity to redesign our healthcare services to be fit for the future, to be higher quality, more efficient, more accessible and patient focused, but do that in the context of not receiving growth in funding. Now, it's very easy to say, of course, it's much harder to actually put into being. And I mentioned earlier on that I'd used a cartoon from 15 years ago. Well, let's go back a little bit further. This is 31 years ago, a paper that I was part of writing that was presented to the Mersey Regional Health Authority Board on how do we start thinking about what can and can't be provided on the NHS because we have no money. And the discussion was around, well, if somebody's chosen to have a tattoo, then why should the NHS fund the removal of that tattoo? Now, you may think that's nice and simple and non-controversial. That was actually implemented in Mersey region back in 1994, and it caused outrage because there's always exceptions. And as soon as you have exceptions, it negates the policy. And actually, it's probably better to leave it to the clinicians to kind of decide. So adult tattoo removal, there was somebody who had an expletive tattooed on his forehead when he was about 18. He was now in his 30s and basically couldn't get a job anywhere because the minute he walked in for an interview, he had this expletive on his head and they wouldn't entertain it. There are people who have mental health issues associated with a former partner's name or photograph tattooed on them somewhere that are suffering real, genuine mental health issues associated with that. So it's not black and white. IVF, I've lost track of the number of times the IVF debate has gone round and round and round. I don't think there's anybody in this room that would disagree that IVF should be offered, but what's the cutoff in terms of age? What's the cutoff in terms of size of the woman concerned? What's the cutoff in terms of number of cycles? We know that once you get past the third cycle of IVF, the likelihood of success absolutely plummets. So is it a good use of resource to continue? If that's you or your partner, the answer to that question is almost always yes. But if you look at it from a population basis, it's a very different question. Reversal of vasectomy. Somebody's chosen to have a vasectomy. So reversal of vasectomy is not a successful procedure by and large, has a very low success rate. So should the NHS be doing it? So again, that was considered, no, well, let's stop doing that. The NHS will stop doing something until you're approached with somebody who, true story, who lost his wife and 2 children in a tragic car accident, who remarried and wanted to have a family again. And then you suddenly say, well, of course there needs to be exceptions. And this one's an interesting one. This was a drug for treatment of a brain tumor. It didn't cure people, but it gave them several months more of symptom-free life. Problem is, it costs £250,000 per person. So if we've got limited resources, do we spend it on that patient, giving them more years of symptom-free life? Or do we spend it on doing a lot more cataract surgery, a lot more hip surgery, a lot more knee surgery? And these are the really difficult decisions, which is why one of the jewels in the crown of our NHS architecture is actually NICE, because the National Institute for Clinical Health Excellence helps take some of these decisions away from practicing frontline clinicians, because their job is to take a population overview, whereas the clinician's job is to do the very best for the patient in front of them at any given one time. So I'm moving a bit further forward to 2009. 2009, we introduced something called QUIP in the NHS, which is quality, innovation, productivity, and prevention. Now, QUIP was seen as the way forward to redesign our healthcare systems to produce something that was right for the future. I believe that QUIP is just as valid today as it was in 2009. Why are we not pursuing it? We had a different government in 2009, different colour government, and it was very much seen as a policy that was introduced by the Labour government that we actually had at that time. But a real focus on quality, a real focus on delivering innovation where that innovation makes sense for patients, a real focus on improving productivity, and as I said right at the start, prevention is critically important. But as I also said at the start, this is about managing change. So let's start with the Q, quality. I prefer the NHS National Quality Board definition, which is here, which is a focus on clinical effectiveness. Are we doing the right thing for people? Are we getting the best possible outcomes that we actually can? But then a focus on safety. We have roughly one never event every day in the National Health Service. The clue's in the name, never event, things that should never happen. So this is wrong patient surgery, wrong site surgery, incompatible blood transfusion, something left inside a patient, etc., etc., suicide in a hospital premise, etc. Apart from the damage to the individual patients associated with that, these cost the NHS a fortune. And if we actually get things right and stop making some of the mistakes that we make, we will have more money to spend on other areas. And just as important, patient experience. So this is everything from the quality of the administrative processes right through to how long did I have to wait, right the way through to did the clinician properly explain what was going to happen to me? Did I understand the procedure, et cetera, et cetera. The WHO definition is basically exactly the same, but they split it down into 7 subcategories instead of the 3. Innovation. We're really, really good in this country at coming up with new ideas, new concepts, new ways of doing things. We are really, really, really bad at mainstreaming them. So data from NHS England in 2017, and this hasn't changed hugely, by the way, is that we spend £1.2 billion a year on research, on new ways of doing things, and we then spend £50 million a year on putting those into practice. There's research from both the United States and the United Kingdom that shows that for a really good new way of doing something, it takes 15 years for it to become mainstreamed across the healthcare system. We've got to shrink that. There are some really new, novel approaches to doing things out there at the moment, and we can't allow resistance to change and reluctance to change to slow them down. Equally, we need to properly resource it. So if I was a factory producing widgets and we wanted to completely redesign the process for producing widgets, what would we do? We'd close the production line down for a couple of weeks. We'd retrain all our staff. We'd restart the production line, making sure that everything was working properly, running at a slower pace. And then we gradually turn the dial up to get back to full speed operating. We almost never do that in healthcare. Now, I accept it's difficult when you've got the urgent and emergency demand, but it's not impossible with some aspects of elective care, but we don't do it. We spend a tiny amount of money on retraining people in different ways of doing things, and we need to think about that. And we need to really focus on this. Invention, tick, good at that. Adoption, we quite often get some early adopters, some pilot sites for things. Diffusion, absolutely awful at it. We have to find a way of spreading best practice. So for public health colleagues, I know this is an old slide, but I really like it. We talk about public health interventions actually having an impact on the health of the population, but also on the cost of the NHS. So 1 or 2 of you are in the room are as old as me, and you'll remember when we used to go into pubs and restaurants and cinemas, and it was full of clouds of smoke because everybody used to smoke in public places. We then introduced the smoke-free legislation that made it illegal to smoke in public places, and it was introduced here, just where that green line starts. So what does this graph show? This graph shows the number of people admitted to hospital with a myocardial infarction. Look what happens when we ban smoking in public places. Now, some of that will be smokers, and you'll see here that it was estimated that 300,000 people stopped smoking as a secondary benefit of introducing the ban on smoking in public places. That's not all of this by any means. This is passive smoking. This was people who were suffering from an acute myocardial infarction as a result of being exposed to secondhand smoke. And clearly it was the right thing to do for the population. But if you look at what this level of AMIs are in future, simply reducing, banning smoking in public places produced an annual savings to the National Health Service of £17 million a year, apart from being the right thing for the population. And there are so many other examples, but that's my favourite one. Okay, so in the last part of the presentation, I want to look forward. And I want to talk about the next 15 years and how we try and produce a sustainable healthcare system. And I'm going to borrow from a document that is going to be published at some stage by NHS England now. And it'll be out at some stage this year, but it's not actually published yet. But in that document, it's a rewrite of a document that was first published about 10 years ago, called Framework 15, that looks forward for 15 years and talks about what are the factors affecting healthcare in countries around the world. So apologies, I'm not sure how clear that is, but don't worry, I'm going to talk through these one by one. So let's start with the first one, which is around demographics and disease. So remember that ticking time bomb that we talked about at the start if we don't get serious about prevention. So in 2037, we're going to have 55% more people aged over 85 than we had in 2022. 55% more people aged over 85. 70% of NHS resources are consumed by managing people who've been diagnosed with long-term conditions, one or more long-term conditions. Unless we do something to reverse the current trends, 2/3 of people over 65 will have at least one long-term condition, and 1/3 of people aged over 65 will have mental health conditions. It's not rocket science to understand that the use of health and social care resources rises rapidly with age. So the average health spending is 5 times greater for an 85-year-old than it is for a 30-year-old. So just think what's going to happen with this massive explosion, which actually is in itself a success story because we're keeping people alive for longer, but we're not keeping them alive in good health. People are living longer with poor health and making ever increasing demands on the NHS. So we actually need a completely new paradigm of care, which is focused on health creation, people understanding what are the determinants of their health, how they can maintain themselves in a fit and healthy condition for as long as possible. But also, how do we make sure that we've got a workforce that provides the generalist skills that we're going to need for this population with multiple long-term conditions? I don't know if you can see this graph in the middle, but the shaded area is the population in mid-2012, and the line around the outside is the projected population in 2037. So if you look at these areas here, for men and women, that's where we're seeing the huge growth, and that's where we're seeing the huge demand coming through in the NHS. People who need care and support, patients, carer expectations, they're changing. We're all becoming more consumerist, and that consumerist approach to healthcare is now becoming more and more apparent. So if I go back to myself being a child, then banks were open 4.5 days a week, but they kind of opened about 10 o'clock in the morning, shut about 3:30 in the afternoon. And they didn't open at all on Wednesday afternoons, if you remember. What do we have now? Well, we have 24-hour banking, we have internet banking, we have telephone banking, we've got a hole-in-the-wall cash machine, if anybody even uses cash these days. Completely changed. Now, it's changed because society has driven it that way. We used to have shops that were open, perhaps on a Saturday morning, certainly closed on a Wednesday afternoon, open Monday, Tuesday, Thursday, Friday, 9 to 5. But we as consumers have demanded something different. Now, I would argue that we as consumers are now demanding something very different out of the NHS, but we've still got a workforce that's reluctant to provide it, partly because they're so busy in the core hours. That I know plenty of people that would willingly work evenings, Saturdays, Sundays, as long as they could guarantee that it would actually reduce their workload on some of the hours. Health app downloads, they're now running at over 150 million. Apps in the NHS. These are poorly controlled in many cases. Some of the advice that people are getting is complete and utter rubbish. Google every quarter publish details of what people are searching for using Google. I'm not going to tell you what the number one is, but I'll let you work that one out for yourselves. But the number two Google search is anything related to health conditions, illnesses, diseases, maintaining good health. So people are using the internet all the time to access healthcare information. We're also seeing a growth in patients becoming members of what we call in communities of health. So if you go onto Facebook, you will find a type 2 diabetes group on Facebook. You will find a group on Facebook for almost every condition you have ever heard of. And of course, these are global. So people are comparing what's happening in the United States with New Zealand, with Australia, with the UK. And they're then asking questions about, well, if this is how it's being handled and managed in the US, why can't I have it here in the UK? You're getting more and more patient involvement. A recent survey, 91% of cancer patients want to be actively involved in decisions about their care. If you compare that figure with 20 years ago, the figure was about 10%. So the concept of paternalism, where we are going to tell you what we're going to do to you, when we're going to do it, and how we're going to do it, because we know what's right for you, has completely disappeared from many, but not all aspects of healthcare. Because, of course, this capacity to be engaged is not distributed equally across society. Some people have better access to technology than others. Some people know how to use it better than others. Public expectations of quality are increasing all the time, which is why we're seeing more criticism of the NHS, because the quality of care using that broad definition isn't increasing at the same pace as expectations. Now, here's an interesting one. I don't know how many people are in this room, 80, let's say. I absolutely guarantee that if anybody in this room has got anything wrong with you, you will know as much, if not more, about that condition than most healthcare professionals you'll ever come into contact with. Because you're all clever people, you've all got access to technology, and you will be Googling it. A GP friend of mine said to me recently that he had a patient with a relatively obscure condition who I'd booked in for an appointment to see him, and he said, "Oh, thanks very much for seeing me, Doc. I'd like to discuss the paper in last week's New England Journal of Medicine with you." The GP concerned hadn't even picked up last week's New England Journal of Medicine, let alone, read it, digested it, and wondered how it was going to apply to this particular patient. So the expert patient is becoming more and more real as time goes by, and we are all becoming far more knowledgeable, which actually means that the job of clinicians is changing. And I think we need to recognize that, both in how we educate and train our clinicians in the future, but in terms of some of the interactions that we see. So, workforce. Workforce crisis, not enough people in the NHS. True, but did you know that the clinical workforce in the NHS increased by 20.5% between 2010 and 2021? Do you know that we have got more clinicians working in the NHS today than we had before the COVID pandemic as whole-time equivalents? Doesn't feel like it. So why doesn't it feel like it? Well, we're dealing with COVID backlog. We're dealing with huge pressures on the service. We're dealing with people with very complex conditions. People are much more knowledgeable. It takes longer to have a conversation with somebody who knows everything about their condition than it does to simply tell somebody what you're going to do to them. So the conversations are becoming more complex and more evolved. So we do have more people, and I think we shouldn't criticize politicians when they say that, because it is actually true. We have got more people, but the workload has gone up a lot more than 20.5% in that same period. Therefore, the pressure on each of those individuals has increased hugely. Despite plans to move more care to the community, this has been, as long as I've been involved in healthcare management, the whole philosophy has been, let's make sure we do as much as we possibly can in primary care, and we should view secondary care as only something that we access when we can't treat somebody or look after somebody or diagnose somebody in primary care. So we've been talking about this going back to certainly the 1990s. So have we grown the workforce in primary and community care? No. So we say we want to do it, but we're not actually doing it. So the percentage of nurses and midwives working in the acute sector compared to the community was exactly the same in 2021 as it was in 2001. So 80% of all nurses and midwives work in the acute sector, 20% work in the community. But if we're trying to shift all this work, do we need to grow the workforce in the community to be able to take the workload on? We also mustn't forget that the overwhelming majority of caring and well-being, of caring for people's well-being, is actually undertaken by unpaid people, relatives, friends. They are the people who provide the majority of caring. And the latest estimate is there are 9 million unpaid carers across the United Kingdom who are providing some form of care for a family member or a friend. We've seen a huge expansion in new roles. I have a little bit of a problem with this, not with the new roles, because they're all well thought out and the logic, the rationale behind what the new roles are going to do is always there, but we never get rid of any. So we keep bringing more and more and more new roles into the NHS. We never actually take anything out. We never actually step back and say, do we really intend to have a system with 252 different role descriptors for different jobs, people? If we started with a blank piece of paper, would we really have a system with 252 jobs? No, of course we wouldn't. So do we actually need to sit down and say, have we got this right? You know, of course we need the skills in the NHS, but are we creating silos? And then we try and address those by moving towards advanced practice for a number of roles. I just think we need a review. Controversial, but I think we need to look at it. Our international workforce has doubled between 2014 to 2022 to 16%. We're recruiting more and more from overseas. Actually, having a diverse workforce is healthy for the NHS because we bring in different views, different perspectives, different ideas. But the main reason this is happening is because in some cases, we're not training enough of our own. In other cases, our own are leaving to work elsewhere. Again, I don't particularly have a problem with that because people who leave to go and work elsewhere, who then come back to the UK, often come back as a much richer individual in terms of what they can offer. But we need to make sure that this undersupply, which is the greatest risk facing our healthcare system and social care system, with the WHO estimate of 10 million shortage of healthcare professionals by 2030, does not completely destroy our ability to provide healthcare in this country. Again, I'm being slightly controversial with this last point here. The NHS, to me, doesn't feel hugely different when it comes to employment practices than it did when I joined the NHS in the early 1990s. But when I joined the NHS in 1990s, the majority of the workforce were baby boomers. We now have the majority of the workforce who are millennials. And in fact, there's only a very, very small number of very elderly people like Trevor and myself that fall into this category of baby boomers. You know, if you look Generation X, people who are born from 65 onwards, then Generation Y, these are the groups that are now the mainstream employees. They want something different out of life. They want a very different work-life balance. And the things that motivated baby boomers do not motivate the millennials. We need to create an employer that is responsive to the needs of millennials and not to the needs of people like myself. I do hasten to add, I'm only just a baby boomer. Socioeconomic and environmental factors. So what are the drivers of cost? Expectations, we've already talked about. Burden of disease, we've already talked about. Suboptimal allocation of resources. Have we got the spend in the right place between primary care, secondary care? Have we got the spend in the right place between physical health and mental health? The answer is no, by the way, to that question as well. Have we got the spend in the right place between prevention and treatment? We need to really consider how we use the limited money that we've got. Rising costs. Pre the last few years, I always used to use a rule of 1.5, that if you went back for 30 years, then it was roughly 1.5% of costs in the NHS were associated on an annual basis with technological advances, and general inflation in the NHS always used to run at 1.5% above the consumer price index inflation. So the NHS always used to cost about 3% more than inflation. Now that's kind of gone out the window over the last couple of years, but that's one of the reasons why money becomes really tight if we get funded at inflation levels, because we spend more than that. We need a real focus, as I said earlier, on getting it right the first time and on quality of care. But actually, in many cases, improving the quality of care costs money. It pays itself back time after time, but you need an injection of money up front to be able to improve the quality of care that you're actually delivering. And workforce is a current cost driver. Who knows where the current doctors' pay disputes with the government is going to end, but what's for sure is it's going to end up costing more money than is currently spent on doctors' salary. And if that is not funded in full, that then becomes a pressure on the NHS in the same way as we had with many other Agenda for Change members of staff over the last year. So what do we do about it? Well, we can spend less. We said we can ration. Doesn't work. We never actually come up with anything we can ration. What we do is let waiting lists grow. That becomes our safety valve, but is hated by the population, and people's conditions do deteriorate while they're waiting, particularly if they're waiting for diagnostic treatments at this end. Or we can shift the burden from the state. I already mentioned the example in Australia. It's not going to happen. I really can't see any government deciding that the NHS days are up as a fully funded universal healthcare system. We'll see some playing around with prescription charges and dental charges and optometry charges and things like that, but I really don't believe we're going to see a significant shift from the state. So we can spend more, so we can prioritize health over education, leasing, or pensions. Very difficult decisions to make. Or we can increase taxation or other contributions to the NHS. Or, as I said at the start, we can focus on our overall efficiency and primary and secondary prevention. I'm going to jump over these because I'm behind where I wanted to be. Just very quickly on sustainability. If we're talking about creating a sustainable healthcare system, we need to think about the impact that our healthcare system has on the environment. And it's a topic that we don't talk about very often. We are a very significant polluter. And as many other aspects of society clean up their act, we are going to have to do the same. So we are now the only legal user that vents into the atmosphere of chlorofluorocarbons, anesthetic agents. So, you know, we give somebody an anesthetic and it all goes straight out into the atmosphere. Well, you're probably aware that we've banned them in fridges and all sorts of other household appliances because of the damage they do to the environment. So we need to clean up what we're doing. We need to look at how we're building premises for the future, the supply chain, how we manage our waste. The amount of single-use items that we throw away is phenomenal. And of course, it's grown hugely because you'll remember the whole CJD issue when we stopped using sterilizable products and moved to single use. It's all going to go back the other way again. It's got to go back the other way because it's not sustainable what we're throwing away at the moment. And the move towards digital records and away from paper is not happening quickly enough in our healthcare system. There's multiple reasons for that, for wanting to push that, one of which is this environmental factor. So prediction and prevention versus diagnosis and treatment. We need to make that shift. Getting it right the first time we do something. There's a really good initiative called Get It Right First Time that is a real eye-opener if you want to read any of the Get It Right First Time reports that are available on the internet. It's led by Professor Tim Briggs, who's an orthopedic surgeon, who is a force to be reckoned with. And he has stood up to his other orthopedic surgeons and said, I don't buy any of this stuff about why we need to use 10 different implants. These 3 are perfectly adequate. And if we use these 3, we can actually save the NHS a lot of money by better procurement. And we're starting to see more and more Get It Right First Time reports come through. New to follow-up ratio. In some clinics, we're still seeing far too many follow-up patients, some of which are taking slots that can be used for new patients. Who does what? Top of license. For a significant percentage of the time, we need doctors to be doing what only doctors can do. We need nurses to be doing only what registered nurses can do, et cetera, through all the professions. And to do that, we need to make sure that we've got clerical support in place. We need to make sure that we've got the healthcare support workforce in place to free people up to operate at the horrible American term, but top of their license, what we're actually paying people to do. And we need to rethink how we use technology. We'll come on to that briefly. So, impact of technology. The last 5 minutes, I want to just talk a little bit about digital data, genomics, and the impact that these are really going to have on our healthcare systems. So, remote consultation, we're already using it. Some people like it, some people hate it. And that's clinicians and patients. For some people, it's a really good way of engaging with their GP or somebody else, usually over something transactional, to get what it is that they need. Other people really want to sit down and talk to somebody about it. So the answer to this is going to be a mixed economy. Remote surveillance and support. We're already seeing the Internet of Things being a really important way of providing feedback and input to a healthcare provider on what's happening to an individual. We know, for example, that once you get past 85, we all become more and more creatures of habit. And once you get past 85, there is a time slot in the morning in which you will always turn your kettle on or always turn your toaster on. If we connect your kettle and toaster to the internet and you don't turn your kettle and toaster on in that 15 minutes, then you're either not there, you've gone to visit friends or family, or there's something wrong. And there's some really interesting research about how we can use some very simple technology such as this to start flagging up some alerts. This started with pressure sensors in the floor. So if somebody falls, the pressure sensors would register that somebody's fallen and they could trigger help for you. Long way to go with that. Actually, let me jump on because I think this is probably a better slide. So this is a Cisco Health booth. They exist. They were piloted in Scotland. You go in, you sit down. The seat weighs you. It measures your temperature. It measures your respiration. You put your hand on a pad. It measures your heart rate. It measures your pulse oximetry. It's measuring your hemoglobin through a little thumb prick, finger prick of blood that it takes and running a series of other tests at the same time. Everything is being processed through a black box, and then you're having a conversation with a triage nurse or whatever professional who is talking to you through the video screen. If you need a medical opinion, you're put through real time to a clinician who, of course, could be anywhere in the world. Mix this up a bit. Could be in South Africa. Doctors in South Africa in our salaries earn less than 50% of what our doctors do. So, opportunities and threats associated with some of this. And then if you require medication, you don't get a prescription because there's a dispensing robot built into this that spits the tablets or the cream or whatever it may be out of the slot in front of you, and you take it home with you. Would you use it? I'd use it for some things. I wouldn't use it for others. And I think if we could take 25% of work in general practice away to free the staff of the general practice up to see people and to treat people who really need them, then actually I think that has got some real benefits. This was just an example of what I said earlier about people in the audience knowing more about things than their healthcare provider does. This lady was actually a retired professor of pharmacy who had access to all the information in the world on her iPad, which she promptly Googled when somebody came to tell her that her medication was going to change. And then she asked some of the most complicated questions about pharmacology to this poor junior doctor who was at the end of her bed, who apparently did an impersonation of a goldfish. So society is changing. And again, this example here, Internet of Things, you see people walking around with blood glucose monitors on their arms now. They're feeding information to their own phone, but they can also be feeding it to GP practices. And there's all sorts of other information you can capture. Some of you may have heard me talk about this before. I love this. It's a Garmin watch. I don't understand half of what it tells me, but I love it. What I do know is I've had COVID on 3 occasions. And at the time, I was testing daily because of the job I was doing. And at each of those 3 occasions, my watch told me something was wrong 24 hours before I tested positive. Because there's something that it calls a stress indicator that looks at heart rate variability and all sorts of things. That rocketed up. It normally, for me, hovers around 30. That rocketed up to 90 on each of the 3 occasions the day before I've had COVID. So huge amounts to come out of these. But unfortunately, what these do as well, the GPs in the audience, they produce a lot of fit, well, healthy people wanting to come to talk to their GPs about heart rate variability and various other things that have no clinical significance whatsoever. And then concluding, genomics, big one. We are probably entering an era of being able to predict and prevent many diseases much more accurately than we ever have done in the past. There is a view that within the next 7 years, every citizen of the United Kingdom aged over 18 will be able to have a whole genome sequence undertaken. It'll cost less than £100 by then. And for many people, that will then give you a prediction associated with particular diseases. So I've done mine, paid for it myself. I've got an increased risk of developing gout, so I'll lay off the red wine. I've got an increased risk of developing skin cancer, which is actually true because several of my relatives have got a similar risk. There's some medications that there's no point in me taking because I don't metabolize them properly and therefore they won't do me any good. But other than that, I've not really got very much wrong with me that's predicted through genome sequencing. I did think after I'd happily signed up for this and had it done, what do I do if it comes back and says you're at very high risk of X? How do you actually process that? But it's coming. This is not something that is, 30, 40, 50 years away. This is here now. We also have a slight problem that if you believe the data out of Manchester University, 8 people in this room, assuming we've got 80 of us here, your dad isn't who you think it is. So we've got non-paternity present in 10% of the population. Now at the moment, if we do a genetic test, we don't tell you. Because the question is, have I inherited? Answer, yes or no. We don't say no because he's not your dad, okay? But if we move to a situation where we are sequencing the whole population, it then becomes very obvious whether he's your dad or not. And websites or screening services, sequencing services, such as 23andMe are already finding this. So I did mine through 23andMe. Both my kids are on it. Fortunately, it shows onto it, these are your children, it actually says. If I'd done both of them and one of them hadn't appeared, but the serious side of this is this going to destabilize families? Because I actually don't believe that if the NHS holds information about you, we can refuse to share it with you. I believe this has to be publicly available. And then there's the whole ethical issue about what do you do about children. So do we sequence babies at birth? Congratulations, Mr. and Mrs. Smith, on the birth of your baby daughter. But you need to know that she's got a significant increased chance of developing breast cancer by the time she's 50. Do we wait until they're 18 and they get a little electronic envelope on their 18th birthday? That how we handle all of this has got to be thought through and got to be determined. But it's a game changer because it takes us into precision medicine. And this is where we're going for the future. First of all, screening tailored to individuals. So if you're at a higher risk of prostate cancer, then you are the people who we will target for prostate cancer screening or breast cancer or whatever it may be. Precision medicine in terms of drugs. Until relatively recently, everybody thought that one particular form of leukemia was exactly the same because it looked the same down a microscope. It's not. It's actually 10 entirely different diseases, which has just answered the question about why chemotherapy works for some people and not others. So these are the sort of things that are happening all the time with genomics. One thing I didn't mention when it comes to the impact of artificial intelligence is the impact on people's jobs. It's coming. We already know that for mammograms, breast x-rays, that the machine reading is better than the human eye. That then takes us to an interesting point medico-legally, because if this is better than this, and we choose to use this, does that open up a liability? I think the answer to that is yes, by the way, and this is certainly being tested in the United States at the moment. So radiology, histopathology, pattern recognition, color recognition, takes years of training for people to be able to diagnose cancers, looking down a microscope. Through machine learning, we're starting to see some very good results, which are not there yet, but they will be soon. So what impact does that have on the workforce? So I am going to conclude because of time. Basically, I think the three areas that we need to think about for the future are the shape of care. How do we produce a more equitable care system that's more focused on health rather than sickness, that's more focused on primary care rather than secondary care? How do we create a working environment that is created for millennials and Generation Z and not something that's kind of a hangover of baby boomers? Because if we don't do that, we will lose a much more significant percentage of the workforce than we've already lost to date. I couldn't talk to a group such as this without saying, if we're going to change the people we want employed in our healthcare system in the future, we need to change the way in which we train people, and we need education to get on board with this and make sure that we're doing this as a collaborative effect, because that way we'll end up with a workforce that's fit for the future. Henry Ford once said that if you always do what you've always done, you'll always get what you've always got. I don't think that's the case for healthcare anymore. There's too many moving parts in this, and if we continue to do what we've already done, the system is going to implode or explode. You can choose which. It's going to collapse. So we cannot continue to do what we do now. But finally, the last slide, last point I want to leave you with is we talked about technology, we talked about doing things differently. But this quote from Health Professionals for a New Century that The Lancet published 15, 14 years ago now still resonates with me. That if any of us are ill, if any of us are seriously ill, what we need is that care, what we need is that compassion, what we need is somebody to talk to, somebody to hold our hand. And we need to find a way, as we introduce more technology, as we introduce artificial intelligence, as we see genomics coming down the line, as digital technology takes over a greater aspect, how do we maintain this kindness, this care, this compassion, this interaction between human beings that is absolutely at the core of healthcare? And I think those are our challenges for the next 15 years. Thank you.
Can I thank all of you in the room for joining us this evening, all of you who are online for also checking in. I'm sure you've all had a fascinating period listening to Ian this evening, so I'm sure you'll join me at the end of it in thanking him once again for a fantastic talk. Thank you.